Hello, welcome back from lunch. I'm John Hooten from Mount Sinai, New York, and I'm going to be moderating this exciting next segment on cervical disc arthroplasty. I think that anyone who's been practicing 15 or 20 years remembers the excitement and the energy in the air when disc arthroplasty first became available. And then 10 years later, I think there was a widespread disappointment that it didn't make as big an impact in the average surgeon's practice as we thought. But I think that there is a change in the air now again, that we're understanding this technology better and understanding better how it might be applied. I'd like to call Dr. Andrew Dailey to give us a lecture on what the literature is telling us.
Thanks so much, John. Nothing like a review of a meta-analysis to get things flowing after lunch, but if this doesn't make you hyper-somnolent, then nothing will. This is going to be a lot of repetition from what Praveen had been talking about. Basically, I'd like to give a shout out to Leo Kim, one of our research residents, who did this meta-analysis looking at midterm and long-term outcomes after TDR in the cervical spine. Basically, we're looking at 5-year and to 10-year follow-ups with these and trying to see what the data shows. None of my disclosures are pertinent to the talk. Basically, we've talked about anterior cervical discectomy being the workhorse for cervical radiculopathy and myelopathy. And everybody knows Dr. Hillebrandt's study and showing that the annual incidence of adjacent segment degeneration was about 3% per year, with the prevalence being almost 20% at 10 years, suggesting that we could do better, perhaps, than fusing the spine. And that's why disc arthroplasty has become available. We can see that about 2/3 of those patients who had new disease after 10 years would need additional surgery in Allen's study, and other people have repeated this with up to 20% of people requiring repeat surgery at 10 years. And the question is it really the natural history of the disc degeneration, as in this person who was treated with conservative treatment for the C5-6 disc herniation, who subsequently developed adjacent segment degeneration, or is it in fact the natural, or is it fusion disease, and as in this patient who had a fusion, who subsequently developed a large disc herniation below the fusion? There's certainly biomechanical effects of the fusion, and Praveen has gone through these, and there's increased strain on the discs adjacent to the fusion, there's increased motion adjacent to the fusion, and disc arthroplasty hopefully should reduce these risks. There's meta-analyses to show that an unrestricted disc reduces symptomatic adjacent level disease requiring surgery. That's from a meta-analysis from Deng. And there's also evidence to show that it lessens radiologic adjacent segment degeneration. Now, what we did was we looked at randomized controlled trials with at least 60-month follow-up and excluded duplicate data. We coned down from 561 articles, and 18 are included in this meta-analysis. We looked at a risk of bias assessment and found a low risk of bias in these papers. And then we did a quality of evidence using the GRADE approach, using GRADE Pro software, and found that there was low grade level evidence in these disc arthroplasty trials for neurologic CSRS, improvement in NDI, improvement in VAS in neck and arm, and radiographic adjacent segment disease, but moderate grade of evidence for SF36, secondary surgery and adverse events, and there was moderate to high level of heterogeneity. Now, what we're going to do is go through these trials, not one by one, but we're going to look at them as forest plots, okay? So you're going to see a lot of forest plots. And the whole idea is that the way we're going to look at this is that by convention, those boxes that are to the left of that vertical line favor cervical disc arthroplasty. Those boxes to the right of that vertical line favor fusion. And you can see here with radiographic adjacent segment disease, at 60-month, 84-month, and 120-month, there's clearly less radiographic adjacent segment disease in the disc arthroplasty patients. Now, you'll notice there's a lot of heterogeneity in how you determine radiographic adjacent segment disease. And for instance, the rate of adjacent segment disease is lower at 120 months than it was at 84 months. This is because they were just reporting more severe adjacent or radiographic adjacent segment disease in those patients that went out to 10 years. But by the same token, you can see consistently across the board, there's less radiographic adjacent segment disease in the arthroplasty patients. Similarly, symptomatic adjacent level disease requiring surgery. There were almost 3,000 arthroplasty patients and 1,000 ACDF patients included. At 84 months, you can see there on that second plot that the rate was 4.1% for the arthroplasty patients and 9.5% for the fusion patients. At almost up to 10 years, it was 9.1% for the arthroplasty patients and 16%, again, for the fusion patients. And again, those two box plots that you see there in the middle show those black boxes significantly to the right, favoring disc arthroplasty for symptomatic adjacent level disease requiring surgery. When we looked at secondary surgical procedures, again, it was lower at certainly 84 months and greater than 108 months for the disc arthroplasty patients compared to the fusion patients. It was relative equivalence, however, at the 60 months, suggesting as we follow these patients out further and further, the secondary surgical procedures seem to be less in the arthroplasty patients. When we looked at secondary surgical procedures at the index level, again, as you might expect, at 60 months, actually the arthroplasty patients had more secondary surgical procedures at the index level. But when you followed them out to 10 years, these secondary surgical procedures at the index level tended to lessen, and they were much higher for the ACDF group than they were for the disc arthroplasty group. And again, these box plots at the bottom show they favor arthroplasty when you follow these patients out to about 10 years. Furthermore, when you look simply at adjacent level disease in secondary surgical procedures, you can see here, again, in the 10-year group, there was a significant difference, 5.6% at adjacent level in the arthroplasty group, but 17% in the anterior cervical discectomy and fusion group. And again, those two box plots that you see there in the middle definitely favor arthroplasty for secondary surgical procedures at adjacent levels after these procedures. So in terms of neurologic success, this was defined as, in each individual trial, as improvement or maintenance of muscle, sensory, or reflex functions. And it was reported in a total of 9 trials. Although it barely made significance, it was statistically significant in favor of arthroplasty, showing that arthroplasty did have a slightly higher neurologic success rate, as Praveen had alluded to in his seminal articles on the Prestige ST. Other clinical outcome measures, they're pretty equivalent. We looked at SF36. That actually showed a slight trend towards favoring the ACDF group. That's hard to explain for me. But really, there was no difference in VAS arm or neck symptoms or adverse events between the arthroplasty groups and between the anterior cervical discectomy and fusion groups. The limitations of this is it's a meta-analysis. So there's a high degree of a heterogeneity due to different methods of radiographic analysis and different reviewers of clinical outcomes. There's wide variations in the disc use. Again, as Praveen alluded to, some of these are constrained, some of them are not as constrained. And so we didn't analyze semi-constrained versus unconstrained discs, but we hope to do so in the future. There are lower rates of follow-up for the ACDF group. This can be a result of treatment and reporting bias, and there's nothing more disappointing than, I think, having one of these patients enrolled in the trials and then randomizing to an ACDF. I mean, these patients were very, very upset. And so there was clearly treatment bias in these trials. There was also, of course, the question of sponsorship of the trials. Many of the ones in North America are industry-sponsored trials, whereas outside of North America, they tended to be independently funded. And so we're looking at this to see if there's any bias that could be affected by the sponsorship of the trials. And then, of course, as with any meta-analysis, we could have missed various trials in here. So in conclusion, the cervical disc arthroplasty group had lower rates of radiographic adjacent segment degeneration at 10 years, symptomatic adjacent segment degeneration requiring surgery at 10 years, and secondary surgical procedures at 10 years. The cervical disc arthroplasties had statistically greater neurologic success, but again, it was very close. But there was equivalence in other outcome measures, suggesting both are durable operations from a neurologic standpoint. But in terms of radiographic adjacent segment degeneration, clearly in this meta-analysis, CDA came out better. So I'd like to thank you for your attention, and thanks for paying attention.
Okay, I think we have time for a couple of questions. You can come up to the mics while we're waiting for the audience. I could ask any of the panelists. few people need a surgery because they have a perfect disc segment. And I think that there are some authors who have talked about more spondylosis being tolerable. And I want to know what your attitudes were about doing disc replacement on a patient with some degree of spondylosis and where you would draw the line.
I can start, John. I think it's an important point you bring up. I think the original studies talked about loss of disc height to a certain extent being a relative contraindication. I'll say in my own practice, as I've gotten better at doing disc replacements and I feel more comfortable getting like really good releases, my primary contraindication is if there's facet arthropathy. But disc height and uncovertebral arthritis, I feel better about doing an arthroplasty, but I do that operation differently than I would for a soft disc herniation because I do really spend a lot of time sort of getting out with a kerrison and sort of biting out and really making sure on an AP radiograph that we're restoring the uncovertebral height. But yeah, I'm curious to hear what others think.
Yeah, for me, disc replacement is a disease of soft disc herniations. And so I really tend to shy away from those spondylotic patients in their 50s, 60s, and 70s. I really do, because I think they go on to have higher failure rates, and it seems to be, need fusions, need revisions, and so forth. So I shy very much away from that spondylotic patient to a great degree, certainly somebody with facet arthropathy.
Any other thoughts?
I agree with that. I tend to steer patients away who are in their 50s, 60s, 70s with a lot of facet arthropathy from arthroplasty. Now, some of them still want an arthroplasty, and they don't really care what you think. They have read on the internet that it's going to be the next greatest thing since sliced bread. They're getting an arthroplasty one way or another. I will say that I went to Taipei as visiting professor, and they were basically putting an arthroplasty in everyone who walked in through the door, and they even have some people with OPLL, mild OPLL, they're putting in arthroplasties. And I thought, this is weird, this is not going to turn out well. But actually, they published their results in JNS Spine. It actually turns out okay. It's not like the patients are, having terrible revision rates. It's not as good as someone who's young with a soft disc, which is my primary indication for doing it. But it wasn't terrible, even if they put it in these spondylotic people.
Shiraz or Praveen, do you, if you have a patient that's very spondylotic, which sort of implants do you use? Does it influence your implant choice?
Yeah, for me, I primarily use a keeled implant just because I like the stability and being able to tell people, that I'm comfortable with them getting back to things. The spondylosis probably has less impact, but sometimes if there's a really collapsed disc where I'm worried, then I'll lean towards one of the devices. Simplify has like the kind of smallest option available that we could still get in. So that's a small consideration.
From the front.
Okay. Sang Lee from Johns Hopkins, Baltimore, Maryland. I got a comment and question about the frame anatomy with the disc arthroplasty topic. So I totally agree with that. Prior frame anatomy is okay with the disc arthroplasty because a few points. Even we think we remove the 50%, if you check the CT scan, it's much smaller. And also, the facet joint is growing back over time. It's in the literature. It's up to 30-40%. I think that's okay with the stabilizing facet. But I think at that point should be tailored because some posterior pathology could be a contraindication of disc arthroplasty. That's a comment. But question to the panel. So, what about, I don't have any experience with frame anatomy after disc arthroplasty. So I'm going to ask questions, experience, any thought?
I think, based on the work we did researching this, I think it is a perfectly viable option. We don't know what the clinical outcomes are. There's really not any existing data. It'd be a great paper to be here at CSRS in the next couple of years. But I think the most important thing, and the thing that I tell everybody, is you just want to make sure you're not sticking your head in the mud with some other problem with your disc implant, mechanical complication, device-related complication that you're ignoring and doing a frame anatomy. You could certainly make that problem worse.
Are we still worried about debris and longevity of the implants. I've heard very few people speaking about that lately.
I'm not so much worried about it. I think that's much more an issue of lumbar arthroplasty and large joint arthroplasty than it is for cervical. The cervical motion-bearing surface is so infinitesimally smaller than those other ones. I have not seen an issue with wear debris and all kinds of foreign body reactions. Or I'll say I have seen it maybe twice in a decade.
Yeah, I agree with Praveen. I think a well-done arthroplasty, you probably don't have that issue. You know, I think if the implants were sized too small or there was like too much end plate removed, there was this issue of like HO or subsidence and probably early wear. There have been some reports on, you know, one of the implants in particular having some issues with wear rate, but I think it's debatable. I think most of it is, it just comes, like, if you're doing an arthroplasty, it is a different operation. And I think the point that Praveen made in the first talk where, you know, unfortunately, we get paid less to do a harder operation that, you know, can go bad in a lot of ways is unfortunate.
It's the elephant in the room.
Yeah.
The front.
Drew Bednar from McMaster University in Ontario, Canada. I came up to ask my question just before you started that discussion, and it's a nice synchronicity. I have experience with about 150 cervical arthroplasties before the Canadian Budget Police caught up to me and shut me down. But they were very early in the release, so they're late. We have lots of 2-year outcomes data that's pretty good, and I followed my people for that year or so and said goodbye. I've had several come back with really problematic late ankyloses in the 8 to 10 year range, and they're ankylosing in flexion when their baseline alignments were very, very good, which I think I can explain, but it's a little flaky. I'd like to ask the panel if they have any experience with this, because it's a really thorny late problem to deal with. The revisions have just been awful.
I'll take a shot at that. The ones that I've seen ankylosed have ankylosed in a neutral, basically straight, you know, neck position. I haven't seen them ankylosed in a kyphotic position. Maybe once or twice in a long time that I've seen that. So I don't know if that's related to the, you know, what you know, product you used for your arthroplasty, but for the most part, when they ankylose, they seem to be, for me, ankylosing neutrally.
Are you seeing early ankyloses or later ones?
No, I usually see it, if I see it somewhere around 5 years. Because I used to follow them all. You know, when I first did them, I was in one of these, you know, US FDA trials. So we followed everybody, and we were really, really, you know, specific to go find them and track them down. In the first 2 years, it really didn't happen. It was, you know, between the 5 and the 10-year mark that I started seeing some of this stuff. So, but they basically turned to an ACDF in neutral.
Thank you.
Front.
Hey there, Pat McNulty. Can you make a couple more comments on the issue of third particle debris? Because my simple concerns are, you've got Scott Blumenthal did a little presentation with revision TDRs, and it seemed like the design with the M6, which has that polyethylene kind of annulus, seemed to have a higher incidence of osteolysis, and that's kind of a different mechanism for third body wear than the traditional poly on metal. And then also make a comment in regards to the simplified disc, which has that ceramic core on peak as its weight-bearing surface. So maybe expand the comments on that, because those are a little different as far as mechanism and basic design.
I have not used the M6, so I can't really comment on that. Shiraz, I don't know.
Yeah, so I agree. I mean, it's very debatable. So this is like, you know, just my opinion. But yeah, I agree. I mean, I think the strands of polyethylene, which are sort of in the core of M6, it has potential to have debris. Now, there are some people that use it and they say it is absolutely not the case. But the ones that I have seen in recent years, especially over the last 2 years that have come into my office, with like early issues of debris, especially where like you could see osteolysis around the end plates, have all been M6. And I don't know if that's just bad luck or if that is a function of the implant. But yeah, I don't use the implant personally. But again, it's just my opinion.
I think it's my opinion as well. And so, not to throw anyone under the bus or anything like that, but it does seem that the ones that I've revised have that osteolysis that is at the superjacent end plate. And it is, I assume, from wear debris.
Yeah, so I'm not familiar with the details of the testing protocols, but obviously it'd be ideal because you got some basic differences in implant design to somehow quantify that third body debris. And, just empirically thinking about the M6, there's a lot more interface, a lot more shearing going on. And I think TBI's done a lot of those studies, and it seems to be an issue with that. But again, the Simplify for me, one of the biggest deterrents for me to do a disc replacement is simply imaging. But now with the Simplify, it's got PEEK with the plasma spray titanium and a ceramic core. The imaging's great. So again, but that's a new kind of design. I've never heard of a ceramic on PEEK as an arthroplasty design. Any comments on that?
I've used Simplify, and I agree. The imaging qualities are really, really good if you need to get a post-operative MRI. But I will say I mostly use Prestige LP, which is a metal-on-metal disc. The MRI protocols now, the one that we use at our hospital is called the Maverick protocol, which is a metal subtraction protocol, and you can get fantastic. I never have had to, in at least the last 3 years now that we've been using Maverick, have had to get a CT myelogram on a patient due to metal issues. And it really came from large joint arthroplasty where they needed to get MRIs to kind of look around. And so then we started using those for our spine cases as well. And the metal subtraction MRIs are really, really good regardless of arthroplasty type. It still, doesn't compare to obviously the Simplify, which that's like its big advantage. But you can get good MRIs with certain MRI protocols with other arthroplasties as well.
So one more simple point, as you perhaps push more into a spondylitic patient that still has reasonable motion, obviously recurrence at the index level is more of a concern, correct? So the other issue is how's the CT imaging? Because even CT can have artifact as well. And again, it's just, with index level concern of recurrent of disease, the imaging's a big deal for me, so. Comments?
I think with, the two that I use the most frequently is Prestige LP and Simplify. The imaging characteristics, CT and MRI, are manageable with current imaging protocols. I think there are differences, and some of these cast more shadow artifact than others. And I think with those two, the Simplify is relatively new, so I don't know what its wear debris issues are going to be 5-10 years down the road. The Prestige LP really didn't have that when we looked at it long-term in 7 years follow-up.
Thank you to all of the panelists. That was a great session.